welcome to our journal club. And today is audit presentation from our center. This audit has been presented already in ESMO GI last month, and our F1 Hora Abu Ali is here to present this order. She has played a significant role in collection data, and I have designed the audit and analyzed it and have done an impact statement. So, Hora, can you come in and start your first slide, please? Thank you.
Hi, good morning all. My name is Hawra. I'm one of the F1. So my audit talk about the burden of venous thromboembolism in pancreatic cancer patient who underwent chemotherapy and the impact of a thromboembolism of a thromboprophylactic on them. So as Dr. Gilani mentioned, this audit was presented last month in ESMO GI in Munich and was published in Supplement of Annual of Oncology Journal last month. And it's also available to be viewed in Oncology Pro through ESMO website online. This is the poster presentation. So as pancreatic cancer considered to be the 7th leading cause of death and associated with increased risk of VTE, it's occur in 20% of pancreatic cancer patients. Most guidelines recommend the VTE prophylactic to reduce the mortality rate. So our aim here to evaluate the burden of VTE and using anticoagulation in pancreatic cancer patients underwent chemotherapy during their 6 years at UHNM. So I collected the data using the electronic patient record, mainly iPortal and Medic Online at Royal Stoke. And then I looked on tumor characteristic, if the patient being on VTE prophylactic, if they have any thrombotic event or bleeding event. And then looked for the patient underwent chemotherapy, either they being on or not prophylactic, and if they develop VTE. So the result here, there was 91 patients diagnosed with pancreatic cancer between 2019 and 2024. And we can see the demographic in this table. There was 44% as a female and 56% are male, and the majority of the tumor located in the head of the pancreas, which account for 31%, and majority of them are metastatic type of cancer. So as I mentioned, there was 91 patients diagnosed with pancreatic cancer, and there was 14 of them, they were on VTE prophylactic, and 5 out of them, they had VTE incident, where 77 of the patients, they are not on VTE prophylactic, and 17 of them, they had developed VTE incident. So 15% of the patients, they did develop VTE within 4 to 6 months of starting chemotherapy. And it's found that pulmonary embolism emerged to be the most prevalent VTE event, as it's been observed in 10 patients, where DVT observed in 5 patients. And there is some incidental visceral venous thrombosis and stroke event, which each account for 3%. So our analysis states that there was 7% of the patients, they were on a prophylactic before starting chemotherapy, and they didn't develop any VTE during the 1-year follow-up. And there are no bleeding complication found in patients who receive anticoagulation, which is our main concern here. So this study demonstrates that 13% of the pancreatic cancer patients who develop VTE, they did not receive prophylactic anticoagulation. So here we're highlighting the importance of primary prophylaxis in this group of patients. So we can see here, this is the real-world evidence demonstrate 9% improvement in VTE event with the primary prophylaxis of VTE with anticoagulation. And corona score recommend to be used for the risk stratification to select the cancer patient who fit for primary prophylactic. From this table, we can see the component of corona score beside the tumor type, which is here pancreatic cancer. So we had 7 patients. They had pre-chemotherapy leukocyte count above 100,000. 2 patients, their hemoglobin less than 10. 17 patients, pre-chemotherapy platelets count above 350,000. And none of our patients had BMI above 35. So prophylactic anticoagulation, it's usually recommended if corona score is above 2. So we can see from this graph, if we following corona score to predict the VTE risk in our patient, we had 59 patients, they scoring 2, 25 patients scoring 3, 7 patients scoring 4. This means most of the patients, they are under intermediate and very high rate for developing VTE event. So in this study, all pancreatic cancer patients, they had a corona score above 3. So the clinical utility of the corona score was not useful in this group patient. So from this audit, given the high incidence of VTE in pancreatic cancer patient undergoing chemotherapy, the primary prophylaxis should be commenced on the absence of bleeding event.
Thank you very much.
Thank you. Do you have any questions?
Thank you, Aurora. This was excellent presentation, and thank you very much for your contribution and dedication for this work. And this was accepted in ESMO, and that was quite encouraging for you as well as for our cancer center. So I will just share my screen. I will just give you a little bit background. Primary prophylaxis. This is a difficult and new paradigm in cancer-associated thrombosis. And I will just go through to you today. So this audit has shown that we have high incidence of VTE in our cancer patients in last 5 years. So incidence was almost 13%, which is usually the case in all studies. So these are my declarations today, but there's no impact of any of them. As you know, malignancy and cancer-associated thrombosis go hand in hand, and almost 20% cases of all cancers, they do develop VTE in their lifetime, but usually they develop in the first few months of their diagnosis when they start on chemotherapy. So it also impacts on mortality, morbidity, and hospitalization. And there are bleeding complications associated with cancer patients. And there is also a recurrent VTE in these patients. If they develop VTE, obviously cancer treatment will be delayed. So there are so many factors we have to consider which can impact the risk of VTE, which could be patient related, for example, high BMI or thrombophilia, age of the patient, sex of the patient, and also some of the cancer related parameters like type of cancer and type of chemotherapy they are receiving, and sometimes their blood parameters as well. And sometimes cancer itself is having a compression on the venous system, which can lead to increased risk of VTE. So there is a case study here. This is a 60-year-old gentleman who had reflexive symptoms for a year and was having some weight loss. He had a CT scan and has been shown locally advanced pancreatic cancer. He was a retired and fit gentleman, but not fit enough for FOLFIRINOX. So oncologist has suggested to start gemcitabine and cisplatin. So what you will recommend for this patient if oncologist is asking you what is the VTE risk of this patient in during first 6 months? So there is no personal history of VTE in this patient. He is having some COPD and ischemic heart disease. He's a middle-aged man. BMI was not very high. Pancreatic cancers usually don't have high BMI. And his lab parameters were 125 gram of hemoglobin, WBC 11.4, platelets 194. And what you will recommend? Will you tell them to reassure, no problem, he has no family history, so no need for VTE prophylaxis? Or will you evaluate with and recommend some prophylactic anticoagulation for this high-risk patient? Or you will just recommend for prophylactic anticoagulation for all cancer patients? Let's go through some data. We have some trials in 20 years ago with low molecular heparin. These trials were for all cancer patients and they were unselected. They have shown that prophylactic low molecular heparin during the chemotherapy was helpful in reducing the incidence of VTE, but at a cost of bleeding. So the incidence of bleeding was quite high in these patients, and also there was daily injections. So this did not catch up. So this data was not implemented. Major guidelines did not recommend. The reason being that number to treat patients were quite high, around about 40 to 50, and number to harm was quite low actually. An incidence of VTE was low even in the placebo, and this is unselected population. So all patients were included in that. And the fear of bleeding among oncologists as well as clinicians and patients were the paramount important factor in this situation. So we need to risk stratify. Obviously, we have to define patients who we can give anticoagulation. So to identify patients at high risk, we have to improve the risk-benefit ratio, reduce the number to treat. If we reduce the number to treat around about 20, that's fine. At the moment, we are actually having with low molecular heparin, with unselected population, it is 50. Current guidelines recommend that we should use validated tool to assess the risk of VTE in cancer patients. And one of the validated tool is Corona score. It actually includes 5 parameters. 2 of them are patient related, like type of cancer at BMI, and 3 of them is blood parameters, pre-chemo hemoglobin, pre-chemo platelets, pre-chemo WBC count. In our study, it came back like 3. So obviously, the risk of VTE in first 6 months were around about 10%. If it is around about 10%, you can actually consider starting prophylactic anticoagulations because the risk of bleeding with anticoagulations is around about 5%. Coming back to our case study, patient was at high risk of bleeding in 3 months. What happened with this patient? This patient actually developed a profound thrombocytopenia after first cycle. That actually creates a little bit more problem in these patients. So managing thrombocytopenia with the cisplatin and platinum-based chemotherapy is a problem. And obviously, this patient was at this very high risk of bleeding. So it's very important that whenever you are stratifying a patient, also consider that is this patient at high risk of bleeding at any time during the treatment of or prophylactic treatment of anticoagulation. Utility of Corona score was questioned in few studies, and because the absolute benefit of Corona score was, it was overestimated, and utility is low. Performance is low in hepatobiliary and pancreatic cancer, as it was seen in our study as well. So this was the study called AVERT trial, done in 2019. 574 patients were followed 180 days with placebo with the apixaban 2.5 milligram, looking for VTE in next 6 months. That the apixaban has reduced VTE incidence significantly, but at a cost of bleeding. Number to treat was reduced to 16, and number to harm was 100. And similarly, there was another study which is called Cassini study. That was rivaroxaban comparing with placebo. in those patients who had newly diagnosed cancer patients undergoing chemotherapy. Around about 1,000 patients were randomized. They were followed for 180 days. It has shown that VTE risk has reduced at a cost of bleeding. And the number to treat was 26 and number to harm was 101. The pooled analysis of these two studies have actually shown that DOACs actually significantly reduce VTE as compared to placebo in this population, and hazard ratio was zero point 0.5. And you can see here drugs also increase the risk of bleeding with hazard ratio of almost 2. Primary prophylaxis with the dogs comes with a cost, which is a bleeding. Bodies have suggested using prophylactic anticoagulation in those patients with coroner score 2 or more. For example, National Cancer Comprehensive Cancer Network, American Society of Oncology, International Society of Thrombosis, and American Society of Thrombosis. All of them has actually suggested to start prophylactic anticoagulation in those patients with coroner score 2 or more. But they have suggested that DOACs can be used, although apixaban and rivaroxaban is off-label at the moment. And we have to consider those patients who can develop bleeding. For example, incidence of thrombocytopenia and GI, GU cancer, and myeloma and proliferative disorders are dealt differently. So after that, Europe caught up last year, and they have suggested in their guidelines that primary prophylaxis is recommended for those patients with high coroner score. And similarly, the NICE guidelines actually has mentioned specifically, if you can see here, do not offer VT. This was old guidelines in 2018, and then they updated in 2019. So now we have actually compared, based our study compared with the NICE recommendations. So they have suggested consider pharmacological VTE prophylaxis with low molecular heparin with the people with pancreatic cancer who are receiving chemotherapy. So in our study, only 7% patients received prophylactic anticoagulation, and none of them had developed bleeding, and none of them had developed VTE. And overall incidence of VTE was 13%. But almost 80% patients did not actually were given prophylactic anticoagulation. And how to implement this evidence? Actually, this is a good evidence, and we can implement it, but it is another science and very difficult to actually implement things. One of the suggestion was to flag electronically for people when they see first patient for chemotherapy consent, but still there is a lot of problems. But what American College of Cardiology has suggested that you can consider primary prophylaxis in ambulatory medical oncology patients, excluding myeloma, myeloproliferative neoplasm, calculate the coroner score. If coroner score is less than 2, do not recommend. If coroner score is more than 2 or 2, then assess for contraindications, drug interactions, bleeding risk. If these are not there, for example, patient is not going for any spinal surgery or spinal injection or any coagulopathy or thrombocytopenia, brain metastasis, or any intervention in next 6 months, then there is no history of bleeding and patient is not having GU, luminal and renal luminal cancer, then you can actually consider DOAC for 6 months or as long as patient is on chemotherapy, but shared decision making is always the case. But the conclusion is that patient with cancer is high risk of thrombosis, and we should balance the competing risk of bleeding. The data does support to adopt thromboprophylaxis in high risk patient using risk assessment tools. We have to consider numerous factors before we decide. The major unmet need is prevailing fear of bleeding is the most important problem. We have come far from warfarin, which is a rat poison, to warfarin and then to dox, we need a breakthrough and no interaction. And we are looking into it. There are future drugs which are factor 11 inhibitor, not factor 10 inhibitors, but we have reached up to factor 10. The factor 11 is the future, and hopefully in future we might get some drug with less bleeding, but same incidence of prevention or treatment of VTE. Hope that helps. And thank you very much for attending today.